Hello, I'm Dimitris Kazukis from HealthManagement.org, and today we have Carsten Engel from ISQua. Dr. Engel, would you briefly introduce yourself and tell us about the mission of the International Society for Quality in Healthcare?
Sure. I'm an anesthesiologist by background. I worked for 20 years as a clinician, but for the past 15 years, I've been working full-time in quality, first as part of the accreditation organization accrediting healthcare in Denmark, and for the last year as CEO of ISQua. ISQua is an organization which mission is to inspire and drive improvement in the quality and safety of healthcare through education and knowledge sharing, external innovation. We support health system and we connect people through global networks. But our tagline is knowledge, network, voice. So what we do is that we gather knowledge, make it accessible through our networks, and thus gives it a voice to those who need it.
So regarding patient safety, how big a problem is patient safety?
It is a significant problem. More than 20 years ago, there were some epidemiological investigations that found that around 10% of patients in hospital were affected by adverse events, and that hasn't changed much in the meantime. We don't know for sure if it's the same kind of events now and then, but the rate is still around 10% are affected by adverse events. One of roundly 14 of these is being fatal, actually, and at least 50% of them are deemed to be preventable. So I would say it is a significant issue still.
What are the challenges in preventing medical errors?
Well, one of the challenges is that healthcare is a complex system. You can do a lot by improving the rules. Any complex system can be made less complicated by having standardized procedures and rules for doing some things, but you can't go all the way by doing this. Then there are, of course, cultural issues. You must accept safety as an issue. You must accept that safety issues is not mainly due to bad people, but that people are working within the system. It is still in many parts of the world a problem to create and maintain it's sometimes called a blame-free culture. I would say I would prefer the expression just culture, where you, of course, occasionally will have to blame somebody for being reckless, but most of the times harm is not caused by recklessness, but by people trying to do their best within systems that are not as strong and as resilient as they could be, because it is complicated to make something as complex as healthcare into a resilient system.
What actions can an organization take to mitigate the impact of adverse events once they happen?
One of the most important things you could do is, in my opinion, to what it has been called mainstreaming patient safety. Patient safety is not something you do besides your operations, normal operations. Of course, you would benefit from having a safety committee and a safety department, but you can't hand over safety to those people and say, okay, you take care of safety, then we do all the rest. Safety must be something you consider every time you consider your processes. Not only how can we deliver, but also how can we deliver safely. Then you must also signal that this is important. So the top management must show commitment in multiple ways and all the time, and not just commitment by words, also commitment by deed. And finally, of course, there must be provided the right infrastructure in order to work as safe as possibly.
You've mentioned in the past safety 1 and safety 2 approaches. which requires a paradigm shift in managing patient safety. What are the challenges in implementing the Safety 2 approach?
Well, first, let me reiterate briefly that Safety 1 is a philosophy that we learn from what goes wrong. And we try to find out how can we prevent this from happening again. And in itself, there is nothing wrong with that approach, but we need to supplement it by another approach because, and that's again because we live in a complex system, work in a complex system. What is it that makes things go right so much of the times in spite of conditions varying sometimes in predictable, other times in unpredictable ways? And one of the core ideas is that there's something we call work as imagined, and then there's something we call work as done. Work as imagined are the procedures. Work as done is what usually happens in everyday practice. And if you work in the Safety 1 paradigm, you might be tempted to think that a deviation from work as imagined is an error that is the cause of harm and must be prevented. In the Safety 2 paradigm, we realize that as conditions vary around us, we need to adapt. And much of the time, these adaptations, deviations from work as imagined, if you will, is what saves the day. Sometimes it makes things go wrong. And we need to understand why things go right most of the time, also to be more knowledgeable about why does it go wrong sometimes. This idea is a very appealing way of thinking. Translating it into action is somewhat more difficult. It's easier to fix a procedure than to fix the way in which we adapt to varying circumstances. This is what we've had to learn. But there are some examples. I've heard about regulatory agencies, for instance, one in the Netherlands, that changed its approach to inspections from looking at compliance with rules and regulations and to a more narrative approach where they asked the organization to describe the way in which they handled safety issues. There are also examples from countries where organizations have used a method called the functional resonance analysis method, or FRAM. It's a way to analyze your work processes and to understand all the things that influence them. And once you try to draw up these process diagrams, you understand why, for instance, incorporating a seemingly straightforward procedure as medication reconciliation, if you think about how is this incorporated in the workflow, that as it actually is, who is actually doing this, what kind of information do they need to be able to do it, how do have they access to this information, how do they pass the information on? When you see this depicted graphically, all of a sudden you understand, well, why it is perhaps not as simple as we had imagined it to be. You can also, when you do things like root cause analysis, if you view the things you look at through what you could call a Safety 2 lens, and to understand the way in which the systems adapt, sometimes for the better, sometimes for the worse, you may be able to reach more robust solutions.
Regarding the healthcare workforce, staffing shortages they're a global problem. How have staffing shortages affected patient safety?
Very, very, very much indeed. There are some alarming figures from the US where during the pandemic years there was seen a great increases in the incidence of totally preventable things as CLABSI, falls, pressure ulcers, catheter-associated urinary tract infections, ventilator-associated events, and MRSA bacteremia. And the way to explain this must be relative staffing shortage. In this case, the staff didn't decrease, but the workload heavily increased. So the relative shortage of staff must have been an important factor behind these deteriorations. And what can we do about that? Well, logically speaking, there are two ways to address it. One is to increase staff. That is not always feasible. The other way is to make work easier for staff, make it easier for the staff available to do the work that needs to be done. And how can we do that? Well, we can reduce complexity, and we do that by prudent standardization. Standardizing everything that can be standardized. It could be both clinical pathways, community protocols. A lot of procedures should be standardized and are widely standardized, but we could do more in that in that aspect. Then, of course, we should leverage technology as much as we can to reduce the burden of work. And then something that, in my opinion, is important to have in mind is flow, the importance of flow. Lots of the time we spent, it was at that time when I was in healthcare, and I suspect it has not been less than that, is we use a lot of time in making things flow, getting information to flow, obtaining the right information, making the patients flow, transfer them from the emergency department to the ICU or the ward, making equipment flow. Attention to flow and understanding flow, understanding variations in flow in order to reduce the friction, find and make more resilient the vulnerabilities, reducing the bottlenecks. I think these are the ways we have to proceed to make healthcare more safe. And I would add that partnering with patients is also an important part of this. Patients are the only one that see the whole patient journey. And they will increasingly not just become passive recipients of care. More and more care is moving out of hospital settings into patients' home. Much of the time, they are the one, not only the patient in the traditional sense, but also the provider of care. And of course, we should leverage their resources. We sometimes, some authors have talked about using patients as scaffolds for the system, allowing them to reach in. And a very simple example of this would be that the patients call the hospital if they haven't received a response to a test they have undergone, where as response was expected, and thus it is revealed that the response is gone missing for some reason. Of course, we should not renounce our own responsibility for making things work, but we should utilize that patients are partners and use them to actively strengthen the security of the system.
How can we better engage the workforce to improve patient safety?
Well, first, as leaders, we must tell them and we must show them that it matters and that we appreciate what they do in order to improve safety. We must create a culture where they speak up if there are concerns. And one of the ways of creating such a culture is by having safety walk-arounds, where you, as top management, come out into your organization and ask people, what concerns do you have here? And it's important, of course, that this is not just a token activity, but that the people who have contributed to you are given feedback to acknowledge that this is heard, this has been taken seriously, and that this can lead to improvements. And you must also train them to understand what safety is, to understand how it is to work in a system like ours, how important it is that you can anticipate what might happen, that you monitor if it actually happens, that you respond if it does in the right way, and that you learn from the way in which you have reacted to previous challenges, and in this way contributes to improving your system continuously. One of the things I actually think that the adverse event reporting systems have contributed to is to improving culture. Occasionally, you learn something and can change something based on an adverse event story. Every time an adverse event is discussed, you send out the signal, this is important, this is something we care about, this is something we take seriously. And that is something that will change culture. And of course, there are some hierarchies that need to be broken down. It needs to be acceptable that anyone in the operating theater speaks up if they have a concern or believe the surgeon is making a mistake or whatever happens. And we say, thank you for being concerned, even if your concern turned out to be wrong up to a certain extent, of course.
What innovations in the next 5 years might improve patient safety?
I think some of the most important innovations will be innovations regarding flow of information, like information technology, but also flow of patients, making able to give a real-time picture about the status of your organization. Because if we say that it's important to anticipate and monitor, then we must also know what's going on. We must understand the mechanisms, how patients flow through our systems, and we must give everyone, including the patients, the opportunity to act quickly if there's a signal that something is going wrong.
So what form would that take as far as innovation?
Well, we have seen examples, for instance, of dashboards, where you on a dashboard at one glance can see the occupancy of beds in a whole hospital or even in a whole hospital system. So you are able to spot where is there a bed for this particular patient where he or she will get the optimal care. We have seen examples where intensive care services can be provided even at a distance from the physical intensive care units by ways of virtual communication possibilities, bringing the expertise to the patients, or a much broader range that in the traditional systems where patients need to come to the place where the expertise is.
Are there any regulatory innovations that might that you see happening in the near future?
Well, it will of course be difficult for regulators to adapt to a way of thinking where you not only monitor for compliance with rules, but also monitor for ability to adapt and respond. But there are around the world people who, I'm not in this business myself, but there are people who have taken up this challenge and are trying to find out ways to reconcile traditional regulation with the kind of safety too and resilience thinking that we have been talking about.
Well, I want to thank you again for taking the time to interview with us.
You're welcome. It was my pleasure.